Hi, this is David Coman. I'm the CEO of Science 37. Thanks for having me today. It's a great topic, the rise of patient-centric applications. And of course, this is near and dear to my heart and something that Science 37 has been focused on for 6 years. And the area of focus for Science 37 really has been about decentralized clinical trials. It's a topic that we've been doing for since the inception, and it's an area that didn't even have a name when we started. So decentralized clinical trials is, it's a whole area of, I guess, the whole industry now has kind of crept up around us. And what I thought I would do is kind of talk about the problem statement a little bit about, why we kind of went down this path originally, and a little bit about, how we go about solving in it, and a little bit about what we think of in terms of the future. So. To start with the problem, when we first looked at this, it's really to solve the big issue, which is the current site-based model excludes patients. And if you look at the total universe of patients that are out there that have a condition that needs to be solved or approached in regards to clinical research, you set up a whole bunch of sites and immediately exclude 2/3 of the world who don't live near one of the sites. And then those who are available to be contacted within them, the data is somewhere around 5 to 8% of any patient who can be contacted or ever contacted to enroll in a study. And of course, less than 1% ever do. And so you have poor contact rates, you have poor enrollment, you have low diversity, and you have high dropout rates. And then you all know about the issue of time and money that's wasted. And you have big organizations that go through these big processes of identification, and then big feasibility processes, and then these long protracted contracting and approval processes, training processes, and then enrollment processes. And of course, there's all this under enrollment that happens, and then long data collection cycles, and there's a lot of medieval processes that are happening as a result. And so all this wastes a lot of time and money. And ultimately, you get to today's issues, which are extended because you have patients now that are even hesitant to come into sites because of COVID. And so it continues to compound and issues extend. And the way we approach the world is to bypass this issue and really bring everything that you need that is available at a site to the comfort of the patient's home. And so you take an investigator who would be at a site and you put them into a telemedicine environment, and you take a nurse who would be at the site and you make them a mobile nurse who would come to the patient's home. And you have a study coordinator who would be sitting behind a desk at a site, and you make them available sitting at the desk at their home, at their own personal home or at our offices, and you connect them through the phone or through a video screen. And you surround the patient through all these people in order to make the patient comfortable to be able to access the study and never have to leave the comfort of their own home, and to be able to use the device that they're comfortable with. And it enables them to access it from anywhere and not be excluded. And it's really important in a lot of therapeutic areas, where travel is prohibitive, but also where you may not even be comfortable going into a clinical trial. And I'll talk through an example that's really important. And this happens to be for major depressive disorder. And for an MDD patient, many of these people don't want to leave their couch to begin with. And I'll talk through the trial design a little bit. And, how do you find the patients? There's a myriad of different ways we find patients. In this case, it could be through an advocacy group, or it could be through, social. It could be a reference from a provider already. But ultimately what happens here is that we go through a series of online questions to get them through an inclusion-exclusion criteria. And we would bring them into through a coordinator ultimately to make sure that they do qualify. And then if you just kind of follow the screen here, we'd take them through a medical record review. And then ultimately the patient has to consent. And through the device that they're comfortable with today, there would be an online, they'd sign off using their finger right on the touchpad, and they would consent to enroll. And then of course you have to get to the data collection processes, and you would do the e-pro, e-diary like you'd expect, the telemedicine guided physical exam, history like we just talked about, ECGs, sample serums, labs, et cetera. All that data collection activity would have to happen. But again, instead of sending them to a facility to do everything, we send the facility to them. And so the CRC, clinical research coordinator, is on the phone with them. The investigator is through the web. We have remote centralized radar team ensuring that these investigators are asking the questions the same way. We have mobile nurses that are available to go into home to do any of the procedures like the ECGs. The important note on this, because it's an MDD study, rater variability is extraordinarily important. And another thing of note here is that this is the MADRS score is something that's really critical. And in this case, the FDA had never done this before, never approved a study to be done in a remote environment. There's a lot of hesitation kind of coming into this study, whether or not this could be done in a remote environment. FDA regulatory authorities really didn't have an issue with it, and they're kind of excited actually about moving forward in this type of environment. The key, of course, was to make sure that you had consistency across all of them. The third party that we used in order to ensure that there was very little rater variability came in and did an assessment. And actually we found that there was less rater variability in our remote investigators than what you experience through the brick and mortar across the different brick and mortar MADRS scale studies that they had actually had done in the past as well. So amazingly consistent feedback from each of them, and this has been an incredibly successful study for us, all completely done in a decentralized environment as we've moved these patients through through the process, completely done in a decentralized manner. So very doable to exercise in a fully decentralized world. But when you think about the future of clinical trials, I don't want people to think about the future of clinical trials purely in a decentralized world. I think, people may think this is crazy for Science 37 to be thinking about it, to be talking about it this way. I actually want you to be thinking about the future of clinical trials in an and environment, not in an or environment. So the future of clinical research, a lot of them are going to be done decentralized, but I think the majority of them are going to be done in a world where some of your patients are going to want to go into a facility. Some of your patients are actually going to want to be managed from the comfort of their own home. And we're going to have to be able to think about it as an industry, how we're going to be able to manage patients who are going to want to have the flexibility to be able to go between, and how some of the investigators are going to want to or need to be able to manage patients who are going to want to have that flexibility. And now we're managing trials that have the variability between those two. And so what I'd like to be able to do is to talk through how we can help you be able to do some of those things offline. And so if you want to talk to me about some of those, how we're actually managing those on behalf of some of other sponsors, I'd be happy to do that offline. So let me know. And with that, enjoy the rest of the conference. Talk to you soon.